All right, hello everybody. Welcome to Grand Rounds for today. And our speaker today is Dr. Gail Daumit. This is really an exciting presentation. And in fact, it's so big that we have to have two people doing the introduction today instead of just one. So I'm going to start, and then Dr. Whitting will continue. So for those of you who are watching this by Zoom, your microphones and cameras are off. They're supposed to be off, and they will be off during the entire presentation. However, we encourage people on Zoom, as people here as well, to interact, especially if you have comments or questions. If you do, please put them in the Q&A box at the bottom of your Zoom screen. Do not use the chat function, which is on, but that's reserved for the panelists and the interpreters to communicate during this session here. So we hope to see some questions coming in from our virtual remote attendees. Also, it's very important for this and all presentations that you complete the evaluation at the end. There'll be a link that comes up on a slide somewhere around 10 to 1. There'll also be an email sent out tomorrow with that link, but it's really helpful to get the evaluation. Okay, so as we know, we have a big focus on medicine and psychiatry here. Dr. Whitting is the academic chief for the new Medicine and Psychiatry division. She invited our speaker today, and I'm going to now turn it over to her to introduce her.
Thank you, Steve, and thank you all for coming out. I think this is going to be a really interesting, stimulating conversation. I'm very pleased to be able to present Dr. Gail Daumit, who is a professor of medicine and has a secondary appointment in psychiatry at Johns Hopkins Medical School, School of Medicine. And she also holds an appointment in epidemiology and health policy and management at the Johns Hopkins Bloomberg School of Public Health. And I've had the privilege of getting to know her, oh gosh, the last, I don't know, no, we won't say, through my former mentor from UPenn, who's an epidemiologist and also at Hopkins. Had the pleasure of being in a class that Gail co-taught with him on the intersection and integration of medicine and psychiatry. And Gail is just a real leader in this field since her very beginning years in research in epidemiology and health services. She was interested in the plight of folks with severe mental illnesses and their premature morbidity from cardiovascular disease as well as diabetes. And has written some very seminal papers in the field, has had amazing funding through NIMH and other funding mechanisms. And I could go on and on, but just want to say that we are super pleased that she was willing to come here today and talk to us about her research work. She has an Alacrity Center focused on folks with severe mental illness and has done some really good work with community involvement as well. So she's going to talk a little bit about that. And without further ado, I'm just gonna let her come up here. Thank you.
Okay, great, thanks. Thank you. Is this on? It doesn't, okay. Thank you so much, Marcia and Steve, for those warm introductions. I am really happy to be here today. Rochester has such a strong reputation in psychiatry. This is my first time visiting the medical center, and in particular, the med psych unit. I was so excited. I'm so excited to be able to be spending time there today. And I hope that this presentation and the questions afterwards discussion will have some interest for you. So thanks in advance. I know some of you probably have to be here as trainees, but thanks for coming anyway in person. And I really appreciate it. So just one addition to the background, which I think might help inform how you think about me, is that I am a general internist, a primary care practicing primary care physician. Okay, so let's go. Okay, I don't have any conflicts of interest or disclosures. Okay. Okay, I don't know if I read this. So basically, the learning objectives, we're going to learn about evidence-based interventions that improve cardiovascular risk factors in people living with serious mental illness. We'll talk some about barriers and look at strategies to more widely implementing evidence-based practices in this population to reduce cardiovascular risk. And I'm going to talk a little bit about partner engagement as part of this work. Okay, I think this is showing I don't have conflicts of interest or financial relationships. I just have my funding from NIH. Okay, I don't know what, okay, keep going, okay. So this is my title slide. This is our NAMI walk. And over every year, the research team I have participates in it. So there's some photos of people I work with and their families. Okay, so, we already talked about this. These are our objectives. Again, part of some people in my research team at the bottom. So I think everyone knows here, I'm sure they do, and this is the work that you all are doing every day, particularly those involved in the med psych unit, but just kind of to frame the talk, what am I doing with my life and the research and work I'm trying to do? I am really trying, and many of us are trying to reduce the marked, profound excess mortality that people living with serious mental illness in the entire world, but particularly, we're focusing on the United States, have. So this is not news and has been documented for decades, but essentially using Maryland Medicaid data as an example and comparing it to kind of standard Maryland data, we see that all-cause mortality and standardized mortality ratio, an epidemiologic term, is over 3 times that in an age, race, sex matched controls. And of course, you all are in the mental health field, practitioners, clinicians. We know that accidental deaths are a big issue. And there is I was able to meet with the suicide prevention researchers this morning. However, the top causes of death are essentially the same causes as in the overall population, except for HIV, which is higher in those living with mental illness. So it's heart disease and cancer, basically. And that's what we're going to focus on today. So again, this background review, many of you already know this, but there are multiple contributors to premature mortality in people living with serious mental illness. My work has mostly focused to date on cardiovascular disease risk factors. So when we think of cardiovascular disease risks, we think of health risk behaviors such as physical inactivity, suboptimal diet, tobacco smoking, and obesity kind of falls into that. And then health risk factors, diabetes, high blood pressure, and high cholesterol. All of those risk factors and risk behaviors are markedly elevated in this population. We know that that's in part from medications that people are taking and also from lifestyle factors and some socioeconomic factors, which we'll talk about in a minute. In addition to these cardiovascular risk factors, a lot of those same risks also will increase cancer risk. We also know, of course, smoking, chronic lung disease, hepatitis leading to liver disease, HIV. So many of the chronic diseases are elevated in people living with serious mental illness. And then, of course, there's all about the quality of healthcare. So once you have something, how are you getting treated? Because if it's not treated appropriately, then of course you're at higher risk for problems. And that's part of what Marcia's work and others are really working on here. Okay, so I don't know if anybody follows kind of the NIH and health, HHS kind of as much as I do, living near Washington and being very dependent on NIH funding. But NIH just recently, in the past month, defined disabilities, people living with disabilities, as a health disparities population. So that includes both physical disabilities and people that many people with serious mental illness are considered also having disabilities. So in the area, in the field that Marcia and I work with, we've been talking about people with serious mental illness as a health disparities population for years, but really it hasn't received kind of the attention and the funding that it is needed. But hopefully maybe now there'll be some change. But as you can see here, many of the issues that people living with serious mental illness have, such as living alone, they may be single, facing discrimination, having issues with health behaviors, as we talked about before, like smoking and physical inactivity, stresses, having issues related to their medical care and environmental factors, like harder to get to a gym, harder to have healthy food. Those are all known cardiovascular risk factors. So this population shares a lot of the same risk factors as those in other disparities populations, for example, racial and ethnic minorities. Okay, so there's a whole literature on everything I said, and that's fine. So like, what about it? Like, what are we doing about it? I'm gonna show you my work, and we can talk about, what do we need to do to move forward. So these are some examples of some interventions to improve cardiovascular or CVD risk factors in people with serious mental illness or SMI. Okay, so we were actually talking last night, Marcia, I, and a few others, about kind of how do we think about, when we think about changing people's lifestyle behavior, such as exercising, eating healthier, quitting smoking. Many of us, I don't have the tobacco smoking part, but many of us are dealing with, how do I do those things in my daily life with everything I have to do? And there have been many interventions that have shown that if, this is the diet you should follow, these are the exercise recommendations. But when we're talking about the patients that you all are taking care of, there are barriers to that, right? So people have psychiatric symptoms that are ongoing. They may have cognitive impairment. I already showed you that they can be considered a disparities population, may not have access to some of the advantages to being able to easily go to a gym, things like that. And so there are a lot of challenges to thinking about how we might do that. On the positive side, if people are engaged in care, often regular behavioral or mental health care, they may be coming frequently to a certain place. There may be places, and this is true in Maryland, where I've done a lot of my work, where people are gathering anyway, like kind of a day program setting where there could be opportunities to help people work on their health. So when we think about, I just want to say it's very cool. No one has ever interpreted something I've done before, so I'm like very honored. Okay, that's great. Okay, so when we think about how would we take into consideration needs people might have, like they are not, it's harder for people to go to a gym, or it's harder for people to go to Whole Foods, to be able to afford that food, or to know what to select, et cetera. We can think about something where we give everybody the same thing, which is like equality. But you see that like if everybody gets the same bicycle, it like doesn't fit for everybody. When we think about equity, and this is the Robert Wood Johnson Foundation's slide that I'm using, we think about equity, we think about like everybody kind of getting something that fits for them, and then they're all able to ride the bicycle. So when we're going to talk about some of the interventions that I've designed and led, those are hopefully moving us towards equity because they're tailored, they're taking into consideration the community that's being served and what would be helpful for them. Okay, and then kind of another like just sort of theme around talking about health behavior change and people living with mental illness is like really believing that it's something that can be accomplished. And I know you all are caring for the community, but I think outside the people that are trained clinicians, it's, you know, common for people to have different biases or unconscious biases or stigma that like, oh, that person will never be able to quit smoking. They've been smoking for 20 years. The meds are making it worse. Or I've had lots of grant reviewers, actually, you know, scientists come back and say that on my own NIH grant. So I think believing that change is possible and should be considered just like for any other patient we're working with is really important. Okay, so let's take a hopefully engaging tour on through some of my journey in this work. So I'm gonna talk with you about some of the intervention trials I've had and some of the things I've learned. So the first randomized clinical trial that I had from the National Institute of Mental Health, it's called the Achieves trial. This was a weight loss study, behavioral weight loss study, and psychiatric day programs in Maryland, which are freestanding programs that are often affiliated with larger behavioral programs like clinics or even residential programs that people with serious mental illness go to 1 to 3 times a week to get to take mostly like group classes and to be able to have some leisure activities. So this study essentially was an 18-month behavioral intervention that included exercise, group exercise, and weight management counseling, group and individual. I'll explain the intervention a little bit more on the next slide. We had almost 300 people in the trial, and we followed 95% of the people to get a weight at the end, so to get the primary outcome. I think for this reason, and also because we did show a 7-pound or 3.5 kilogram weight loss between intervention and control, that it was published in the New England Journal, which was considered, I mean, I still think is like it's hard for studies in this population to be able to be published in those kinds of journals. So it was kind of the start of something of really showing, people had not showed before in a rigorous way that people living with serious mental illness would change their diet and lose weight. It seems like really basic because it was several years ago. And certainly I thought, of course, that it was possible, but at the time it had, and hopefully still has, an impact. So essentially in this study, we had divided the intervention into kind of an initial 6-month phase that was more intense, and then one from 7 to 18 months based on general population studies that we based it off of, which is relevant. I'll explain why that's relevant in a minute. And essentially, like I said before, we had a combination of group and individual weight management, and then we had group exercise. Most of the intervention was delivered by my staff. Some of the exercise was delivered by the psychiatric rehabilitation staff. So that's relevant too for kind of what I'm going to say coming up. And so, okay. So what about this thing? Why did it work? Like, who really cares? What was the difference between like what I tried to do and like if people had just, you know, gone to their regular getting an intervention for everybody else? So we had some strategies that we employed that were specifically tailored to the population, which was essentially a middle-aged population with chronic mental illness, mostly schizophrenia spectrum, and bipolar disorder, of a very diverse background, urban and suburban population. So one of the things that we did was we simplified our messaging, and we did a lot of repetition, and we kept things simple. As I was speaking with someone earlier today, we had 5 or 6 messages that repeated in the curriculum: no sugar drinks, drink water, eat fruits and vegetables, reduce junk food, and portion size. So those are like these key tenets that were repeated throughout. We also used a motivational interviewing approach, but that was also kind of tailored to the population. When we had exercise classes, unlike, Lifetime or whatever you guys have here, Equinox or whatever, where even when I go in as a new member, I'm like kind of intimidated because it's like very fast and people are jumping all around. We used basic simple movements in the beginning that could be for a range of intensity. We used a lot of repetition, and we specifically designed the intervention so that when we were going to change a movement or add another movement, it was done in a very particular way to build confidence for the participants. Okay, so those are some examples. And then if we look, for example, at the dietary recommendations, Premier was an NIH-funded trial that was for blood pressure reduction in a lifestyle intervention. And if you look, which is what Achieve was based on, if you look at their recommendations, which are, there's just a lot of them here, and like counting calories from fat and sodium intake and how much dairy you're doing and these calorie goals, like we just didn't do that. We kept it very simple, as I said before, and these were our recommendations instead. So anyway, we think that these strategies are in large part why we were able to be successful. And then I'm going to show you one more thing about this study, which is that, and this is the overlay of the Achieve trial, which is in red, and the dotted is the intervention group, and this line is control, and the Premier trial, which was it was in the overall general population. And you can see here that the Premier trial is an example of a general population weight loss study where people lose a lot of weight in the beginning and then they gain it back. And actually, when we designed the Achieve intervention, we were very intense for the first 6 months because that's how weight loss trials are. But in our study, you could see that people were losing weight like kind of gradually throughout. And actually at the end, I mean, it was the line, we stopped, but the line was kind of still going down, the whatever slope. And so it took longer for people to lose weight. But then I didn't do like the whole, statistical analysis here, but if you compare, matched control or whatever, but if you compare the magnitude, it's the same magnitude, 7 pounds. So I think what this is saying is that this population may benefit from longer interventions that may be more intense, but if we do that, the outcome can be similar. Okay, fine. So that happened. And then I was like, okay, what else is going on? The programs we were working with were like, this is great, but like people are having high blood pressure and they're smoking and they have diabetes. So like, thank you for this weight management program. And like, what do you got now? Like, what else are you giving me? Like, this is like, okay, we're happy, but like, it's not addressing everything. So at the same time, so I was like, okay, I need to like work on something that's going to address like all the risk factors. Great. At the same time this was happening, and I'm not exactly sure what you have in New York. I can't remember if we talked about this last night, but a programs called behavioral health homes were getting started around the country, which are Medicaid programs, which is essentially a nurse, at least in Maryland, is placed in a community mental health program, and they do kind of coordination of care for physical health. They may do some counseling. They communicate with the primary care doctor. They might help with labs for diabetes and things like that. So that was going on all around the country. But most of the studies, or most of the evaluations of those programs, which are mostly not studies, but kind of more in the gray literature, had not really shown that people were quitting smoking or people were having their blood pressure lowered. They showed more screening, like screening for things. And they showed that like people were happy to be in the program, but they weren't actually showing that like cardiovascular risk was like reduced. So this led me to the next study, and this one was funded by the National Heart, Lung, and Blood Institute, and this is called, we call this IDEAL, for kind of ideal cardiovascular risk factors. And essentially, in a nutshell, what we did in this study, which also had, it had around the same number as ACHIEVE, it had 269 participants, is that we randomized people to usual care or to a program that included someone from the psychiatric program that we trained and paid to do counseling around weight, smoking cessation, and kind of like somatic or cardiovascular medication like adherence, like were they taking their diabetes medicine, for example. And then we had a study nurse that acted in a way to do coordination of care and kind of care management in that setting, to work with primary care doctors, to help people get on a statin if they needed that, to work to help get people smoking cessation treatment. And so it was kind of a combination of like real world, because their staff was delivering some of the program, but then we had the study nurse. So essentially what happened was the overall, the primary outcome, which I don't recommend this because it's very difficult, was the Framingham risk score. I don't know if anyone can like have a throwback to medical school or whatever, learning about that, where it's a compilation of different cardiovascular risk factors all together to give you a score about what your risk for a cardiac event would be within 10 years. And so we had a decrease in that score. That was our primary outcome. We had a decrease in that score of like 12.5%. It's considered clinically significant. We also had a decrease in smoking in that study. Okay, so that was that trial. Okay, I'm gonna go through this, whatever. So this is the photo of that. I'll just briefly say that I also had a smoking cessation trial that was this recently in JAMA Psychiatry. That was similar to what I've described with the other trials, except that what we did here was that we combined behavioral counseling and pharmacologic therapy with varenicline or nicotine replacement, et cetera. And also did weight management counseling to try to prevent the weight gain that we know is so common when people quit smoking. We also included people that were not willing to quit right away necessarily. A lot of the smoking cessation trials in the world, and particularly for people with serious mental illness, are only getting people that like say they want to quit within 30 days. They're not larger to say, okay, like we understand you might be considering it. Like, are you kind of interested? Would you be willing to, talk about it with us? And so we had a broader population of people with serious mental illness who smoke, which I think is very relevant, because if we think about all the environmental changes that have gone over the past decade or 20 years or whatever, like you can't smoke in a building, can't smoke in a restaurant, you can't smoke at work. And like a lot of cigarettes are taxed very highly. So like a lot of people, obviously in the overall population have quit. A lot of people also with serious mental illness have quit, but they still have very, very high smoking rates. But a lot of the people that are still smoking are either smoking very heavily and they maybe aren't interested in quitting, or they're smoking kind of, I don't know, lighter smoking. At least this is in Maryland where we did the study. So by including people that weren't necessarily willing to quit right away, we thought that was more generalizable. And we did have a 26% quit rate at 18 months in the intervention group compared to 6% in the control, which 26%, I mean, doesn't sound great, but that's pretty comparable to, what kind of you would get in like a drug efficacy kind of trial, which would be like more like 30+%. Okay, that's that study. Okay, I'm wearing out. Okay, so that's basically, in a nutshell, kind of efficacy trials I've done. I mean, they're in real world settings. Some of them used staff in mental health programs, but essentially they were efficacy trials. The main outcome was a change in physical health, a health outcome with an intervention that was directly delivered to patients. That was what those 3 trials were. And that was great. Like, I am happy. That was like many years of my life, and a lot of thanks to NIH and all my colleagues and who helped and all the patients that were in the studies. But in reality, to actually like do something after that, we would need people in real world settings, not academically affiliated necessarily, to actually say, okay, I want to like implement something like Achieve. I want to implement a behavioral weight loss program. How do I actually do that? Give me the training, give me, the materials, like give me the funding, like how am I doing it? And sort of a premise of all this is kind of that we know people with serious mental illness are seen all over the health system, including in primary care, but a lot of where they're seen is in these community mental health settings. So what to do about all that? And I was fortunate to participate in a World Health Organization guideline development group several years ago that kind of talked about priorities for this group and kind of highlighted, okay, we need to get more evidence-based programs for this population implemented around their physical health. Okay, so this kind of leads up to like what I've been doing kind of in parallel with, a little after some of these trials, but kind of in parallel with some of them, which was to figure out how are we going to be able to start implementing these things more broadly, and how are we doing that like in a scientific way? So this is kind of this world of implementation science, which is trying to shorten the amount of time across all fields that a particular evidence-based practice, like a smoking cessation intervention, for example, would take to get from research to kind of real world dissemination. So NIMH had an announcement for a center type grant that was focused on implementation science. They're called the Alacrity Centers. There's several of them around the country. And so we were able to get funding for that center. And so essentially the whole center's premise is focusing on what I've been doing, working on reducing premature mortality through pilot implementation studies. So, okay, I'm gonna give you kind of an overview of what we're doing. And okay, so essentially the way that worked is there were 3 pilot studies that were part of how you had to apply for the center. So what we did is we took each intervention trial that I just described to you, and there were pilot projects kind of based on all those. So we had one that was based on the weight management program Achieve, one was based on smoking cessation, and one was based on kind of this overall cardiovascular risk reduction. I'm going to give you, okay. The other thing that we did with these projects is that they were small, but like each project, we tried to focus on like a different mental health setting and like different people that would be implementing the intervention. And then kind of when you added up all the projects, they kind of covered pretty much all the cardiovascular risk factors. So, and the idea is that we were piloting and testing implementation strategies. We weren't quite ready to have like a whole big trial to say, okay, like let's test different ways that we can, spread this weight management program. We needed to kind of figure out like what would work. Okay, so I'm gonna show you an example of one of the projects so you can kind of get a flavor for it. Let me just say, just straight out, that like COVID came hard and heavy right as we were implementing, not as we were planning the project, but right as we were trying to go in the field with all these projects, which was definitely a huge challenge. So this project, this one, we call it Achieve D, Achieve Dissemination. It's based on the Achieve weight loss program. Okay, so the goals for this pilot project were to take the weight loss program that I showed you before. It's 18 months long, which was, we loved it because like it's a nice long time for people to lose weight. You saw people needed that time to lose weight, but the bottom line is like, we didn't think the community mental health programs were going to do anything for 18 months. We were just like, that is not going to work. So we shortened the program to 6 months. We then the study was to pilot a program that would help mental health program staff deliver it. So training and also other supports. We randomized the sites to either the regular supports, which were training, and then these things called organizational strategy meetings, which I'll explain in a minute. Either getting that or getting those two things plus like one-on-one coaching from one of our staff that is experienced in weight management. Okay, so our main outcomes actually were whether they delivered the program, the weight management program, and whether the coach, the mental health program staff who was doing it, liked it, had self-efficacy, thought they could do it, and had knowledge. So notice here, for those who care, I don't know, that implementation science, the main outcome is usually not, unless you're doing a special kind of hybrid 2 trial, it's usually not the health outcome. You're sort of taking something that you think the health outcome is already known. We know that if you do the Achieve program, you're going to get weight loss. And then you say, okay, that's not my primary outcome. I can still look at weight, but I really want to look at an implementation outcome, like whether it can be delivered. So that's what this was. So it takes a little bit of a frame shift because the main participants were actually the mental health program staff delivering it. We consented them, they got paid for data collection, et cetera, to be in the project. Okay, so this program, like I said, it was 6 months, and we made some adaptations to what I showed you before. We kind of combined some of the programs so it wasn't so long. You could kind of get exercise and weight management done at the same time. Although, like I said, it was during COVID, so we had to be flexible. And actually, a lot of the centers were ending up delivering some of this remotely. So even though we thought it was going to be in person, it ended up, we tested it in different ways. And then we had repeated the content in a certain way in case people don't come every time, that they could still get the content. The other thing that we did for this that I think is cool, and I'm going to try to show you an example, is that we had peer leaders that we worked with, one in particular, and we created videos for each week of the program so that the staff at the psychiatric day programs that were implementing this did not have to do a whole leader's guide for a group and learn it ahead and read through the whole thing. We had videos that were assisting that person to do it and that also were engaging for the program. So I'm going to see if this works. I'm going to show you a brief little clip. Let's see, I may have to press something. Oh, let me press it. Okay. This is an example of a part of a video.
I now know that energy drinks are also considered sugar drinks. Plus, it says right here on the ingredient list that sugar is the first ingredient. Yikes. I said I would track what I drink. If I have this energy drink, I'll be saying yes to energy drinks and my weight will not go down. I will say no to all sugar drinks. That includes Pepstar and Zip It. I'm going to have water instead. So I'm going to say no to sugar drinks on my tracker.
Okay, all right, that was a success. Sometimes that doesn't work. Okay, so basically, I mean, whatever, that's an example, but people actually loved these. The staff loved them, and so did the clients. Okay. I'm just giving, okay, so this is an example of kind of a strategy, an implementation strategy, they're called, that we used during this Achieve D study to engage the organization, to encourage and work with them to deliver this program. You can see that there were staffing changes, or sometimes clients wouldn't come, et cetera. So we worked with them in that way. So that's an example of one strategy. And the other one I mentioned was coaching. And that was in the sites that were randomized to that. And that was where they were taped delivering a class. And then we reviewed the tape with them and worked with them on their weight management counseling skills. So sort of, what did we find? So we had 18 coaches that worked with us across 8 sites. They all completed the initial training, which during COVID I thought was impressive. However, we had these kind of ongoing trainings that we provided for them also, and that was less successful. I don't want to say I'm surprised because I try really hard to do high quality work, but all of the sessions, so each of the sites across 6 months delivered all of the sessions, or at least one per week, which was our minimum. So that's kind of that, one of those outcomes. We also had high attendance for the other implementation strategies. And then the clients, even though they were kind of secondary outcomes, we did consent them, and we have this cluster design. So it's the statistical significance is not really there, but interestingly, the actual weight change was 4.7 pounds over 6 months, which again, it does not reach statistical significance because of the clustering, but that's actually more than we had in the original ACHIEVE trial. Again, this is just kind of taking pre-post into account, not looking at the 2 different arms, performance coaching and not. So we were very happy with these preliminary outcomes, or these outcomes for this pilot study. Okay. I'm trying to decide if I should stop, because I could stop. Maybe I should stop and answer some questions. Yeah, I could do like my ending one and then see if there's questions. And then I can always go back if so. Okay, so let me do my little summary. So essentially, I think we could all agree that health disparities in cardiovascular risk factors and mortality are very large in people with serious mental illness. And I think we do have some evidence-based interventions. I've showed you some. There are others by other investigators around the country and the world. I still think, regardless of how those are implemented, we don't still know as much about like intensity and duration. I'm not sure, it's going to be hard to get some of those answers in terms of doing large studies and having funders pay for it, but we don't really know kind of like what is the minimum that's needed or how long something needs to be. So I think that's still important. And I think that we really need to scale up, this is an implementation science term, and disseminate evidence-based practices for this population. And it's really multi-level. We didn't go into it as much, but it's the patient level, the community, provider, organizational, policy, the payer. It's very complicated, but very much needed. And that implementation science, an example of which I showed you with the ACHIEVE D project, is a way to get that information, and particularly community engagement is important, which I can go into at another time. So, okay, thanks. That's what I have. Oh, and thank you. Here, I have my thank you. Okay. 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 All right. So I don't know if I should take these down or what you want to do.
Well, why don't you stay there for a minute? Because
Okay.
I think we might get some good discussion going here.
Okay,
I
good.
think this was
Okay.
great, Dr. Daumit. Thank you so much.
Okay.
So there are a lot of key things that I took from this. One being these interventions, I just want to remind everybody, happened in mental health settings.
Oh, right.
So you're going to where the people are, right? Rather than expecting them to come to the health setting, to primary care. We try to think about that similarly in our MIPS program. When patients are at their Strong Ties appointment, we have our primary clinic right next door. So we're trying to capture them when they're in the moment and try to engage them in primary care outcomes. Same thing in the hospital. They're unfortunately hospitalized, but it's also an opportunity for us to really be engaging with them. And sometimes, as we all know, we spend some time a fair amount of time talking about primary care, basic things. We also have been having trouble, and this really helped me to articulate a little bit, what is it that we do that's really different? And I think it's this simplifying and it's tailoring, right? So how can we do the same evidence quality work, but simplify and tailor with our communication strategies, with reminders, doing it over and over again, patience. It's going to take a little bit more time, but you can achieve the same outcome. So that was, I just think that,
Yeah,
that
I
was,
mean,
I'm just reiterating.
Yeah, I mean, I think it's interesting, and we didn't really talk about this ideal intervention so much. I'm sort of going quickly, but like, I think, you know, cataloging what you all are doing in the clinics and the med psych units about what are the actual things that you're doing. These are the things in the ideal intervention, the kind of overall cardiovascular risk reduction intervention that we did, like literally like making sure the primary care physician knows what the cardiovascular risk profile is. Now, in the integrated clinic, you need to do that less, but like coordination, like it's simplifying, but it's also like, okay, you know what, like you, maybe it's someone who is not living with a mental illness, you give them a referral to get their A1C checked, and then, okay, you're gonna see them whenever, you're gonna email them the results or whatever. Use my chart if you guys use that. In this group, it might look very different. It might be making sure that the caregiver or the residential program is aware that this is something that's being worked on, that the person needs to go for a blood draw, that they may or may not want to be accompanied, that the medications are reconciled, that like, it's just more, right?
Absolutely. So I just want to see if folks have questions. Yes. Come in. I'm going to give it to you anyway.
It's like,
Hi, thank you so much. I'm a first-year faculty here, and I just started working in dermatology as an embedded psychiatrist, and it's really fascinating. There are days that I think we shouldn't have our own offices, which is a whole nother conversation. But I'm curious, in terms of cardiovascular risk factors, if you have any thoughts on deprescribing as a specific targeted intervention, given the high degree of polypharmacy, and often, there's not necessarily strong evidence the patient needs to be on that many medications or the doses that they're on.
yeah, so that's a really critically important question. As you can tell, I'm the internist, so I have been, I've thought about with these grants, like, should I talk about kind of, metabolic, making sure people know about the metabolic parameters and, kind of not using certain medications like olanzapine, et cetera, et cetera. And so I will say that I do think that's very important as considerations. I do think that, if that's kind of part of what you mean, I do think that, so interestingly, in all the studies I've done, and again, I'm talking more of a chronic population with chronic mental illness, people who've been on like an average of over 2 to 3 psychotropic medications. And so, I mean, I do think it's an important consideration. I do think that sometimes there's a balance, because like, if you're going to have someone who's like very stable in their daily life and you start switching things, we don't want to, it's a balance, but I think it speaks to having, internists and psychiatrists or other specialists and psychiatrists work very closely together and collaborate and patient preferences. I will say, I mean, for what it's worth, in the sub-analyses, like for example, from the ACHIEVE trial, if you look at the people who are on second generation antipsychotics with a lot of weight gain potential, that the weight loss was the same, for what it's worth. But so I do think behavioral interventions are very important, but we also haven't even really talked about the new weight loss medications. I mean, there's lots of topics here. So yes, you have a good point.
I have a couple of questions here from the chat.
Okay.
So this is from Elizabeth Eisner. What guidelines, if any, did you use for developing language and presentation style for the peer role model in the videos?
Oh, for the videos? Oh, yeah. Well, I hope we used whatever we were supposed to use. I don't want to say I was less involved, because that's the wrong answer, but I have colleagues that I work closely with that scripted the language, and then we did have the peers look at the language. and it was sort of beta or alpha tested or whatever. I don't know if that's like the right answer. I don't know, because like,
Yeah, I can't.
or if you
direct
chat
feedback,
back
but-
that there was like something that wasn't right. But yeah, we did not use, I mean, I've done some work with peers before. I mean, I think peer leaders and peer advocates or whatever, or peer specialists, it's like a very important area of work, particularly in this population that has not really, I think it's like a whole area that needs more. I think kind of the comparison with community health workers is also really important. And so I think more work needs to be done in that area, but I'd be happy to correspond separately with her.
Thank you.
Okay.
And then I have a question from Kim Van Orden, who I think you met earlier today. Thanks for a great presentation. Are you envisioning a portfolio or menu of options as a final package for clinics to deliver so that patients can select behavior change most relevant to them? And any thoughts of including a model for social support or social connection?
Yeah, so it's a great question. And the study that we didn't talk about that we're doing now is, and the ideal intervention does this, but I didn't really describe it. The study we're starting now is based on that one. But like, yes, it's sort of like the goal would be that clinics would have a menu of things they could deliver, assess cardiovascular risk with the patient, an individual patient, and decide with the patient what they want to work on. For example, someone smokes, has diabetes, and high blood pressure. Maybe the person does not want to talk about smoking cessation right now. So even though like if you do the risk calculator, that's going to be like super important. Okay, let's not talk about it now. Let's look at the diabetes. And so we have done that. And I think that's where we need to go from reward. And then for the social support, sorry, was it that like, yeah, I mean, I think social support, I think many individuals, at least our study participants, often have supports, but they're not geared towards these medical comorbidities in a more guideline or formal whatever way. And I think there's a lot of room to kind of involve the team, whether it's someone in the clinic or kind of outside. And so I think that's an important area for the future.
That was great, yeah.
Someone's back
Just
there.
in terms of making decisions, I have some good prioritization tools for you for helping patients figure that out. Where was the other question?
Oh, he was back there.
Oh.
Yeah. Okay.
Thank you so much. I was just curious, in the sort of dissemination study, the last study that you went over, part of the feasibility, I'd imagine, would be how the different community mental health clinics responded to your proposal. And I'd be really interested to know, maybe some that didn't enroll in the
Yes.
study, what were their reasons?
So that's really great. These questions are like, great. Thank you. Thank you so much. Yes. And again, COVID kind of in the middle, right? Of like when we were so I will say that, I mean, my current work is extending past Maryland. However, the study you're talking about was in Maryland. And so we did have relationships with many of the sites, maybe not recent, maybe they were like from they weren't maybe like in the smoking trial, but we had relationships with them. So that helped. There were some sites that were like, no, thank you. We had like a presentation, we met with them. They were like, thank you, try again. Some engaged. And then with COVID, we're like, no, we're really sorry. Some, I mean, these aren't like tons of places, but like, so a couple said no in the beginning. A couple said, no, it's COVID. I said yes before, but no. Then we had like, originally the grant said 10 sites. I mean, whatever, it was a pilot grant. That was already like too big. Probably I wrote it too big. And so I think we did have like 10. And then there was 1 or 2 sites, they were kind of combined in one organization, whatever, that like started it. And we're like, oh no, this is too much. I can't, it's just like COVID and you're asking us to do all this stuff and we can't do it. So I mean, I'm happy to talk about, like Marcia and I were talking about kind of community engagement and how do you do that? And, you know, it has to be that they're getting something, you know, and they probably have to get more. They have to get a lot. These places are very busy and they're understaffed, et cetera, just like I'm sure is here. I mean, not here, but like in your community. So, yeah.
Excellent question. We have one who I think might be from one of our cardiology colleagues. Although a different focus from this talk, in numerous institutions I've worked at, interventionalists have been concerned about doing coronary interventions in patients with serious mental illness out of concern for noncompliance with DAPT. This has always seemed incorrect to me, but the idea is somewhat pervasive amongst cardiologists. Does this come up in your practice, and how does your group address these types of concerns?
Yeah, I mean, this is so critical. So, I mean, you know, I think Ben Druss, a colleague of ours, wrote, like, I don't know, say 20 years ago, many years ago, using Medicare data, I think from New York, showing that individuals with schizophrenia were much less likely to get coronary angiography, and that was even before the anticoagulation recommendations that we have currently. I mean, look, I think that I would say, first of all, we should study that. But more importantly, I think that, you know, this is like a problem because, you know, this is health equity and it's stigma. And if we should do life-saving or, you know, life-prolonging procedures that are indicated and ensure our health systems or whoever we need to ensure that appropriate follow-up is there. Just like if someone has TB and they need observed therapy or whatever it is, that needs to be in place. And so some of the kinds of organizations that like behavioral health homes or what you all have here are examples of ways that someone could be getting that care and it should be paid for.
Completely agree. And this is something that Lisa Rosenbaum, a cardiologist, has written about extensively in New England Journal a couple of years ago about how we just give up on our patients.
Right, yeah, it's real. Yeah, so thank you for bringing that up.
Any other questions from the room?
Okay.
All right. I guess I have one last question, which is, you've had a little bit of a view of at least our inpatient settings for the medicine and psychiatry group, and you're going to be going to the clinic later today, the primary care clinic. What kinds of things, you mentioned already a little bit, some of what you think we could be doing right now, just describing what it is, how we're having our conversations, maybe how we are trying to support patients when they leave. We think a lot about folks who live in psychiatric group homes and how we might be able to deliver something more medical there, some more physical health opportunities for them because they're so focused on the silo of mental health. But what other sorts of things, low-hanging fruit, do you see as possibilities here in this department?
Okay, so I think on the inpatient side, and again, some of this we talked about, but I'll just say it out loud. I think that you all, and you are doing some of this, I think you have the opportunity, despite the fact that they're smaller inpatient units, to do more in-depth evaluation of those passing in and out of the units, patient-reported outcomes, more evaluation of the types of care and services and the staff roles interacting with those patients, more, or not more, I haven't seen everything you've done, but careful evaluation of the health outcomes of kind of through readmissions or whatever other markers in the electronic health record data, compare with kind of a comparison group that maybe has SMI but is not in those units or something like that. So I think that there is still work I think you all could do there. And then I think, well, I can't wait to see the outpatient clinic, but kind of from what we talked about last night, I do think that you all have a unique opportunity to start or expand a registry that could be used as a springboard for cohort studies. You are in a unique situation, I think, if I'm understanding correctly, kind of providing a lot of the community mental health care in the area. You have a relatively stable, large group of over 1,000, maybe close to 1,500 patients. And I think, thinking carefully about making targeted investments in not only capturing electronic health record data, but kind of through an informed consent process, being able to get patient-reported outcomes, biospecimens, would really set you up very well for the future. We do not have community cohorts of individuals living with serious mental illness in the US currently that can be used for really any kind of grants or funding or studies. That does not exist. And I think both kind of, I mean, I think to move ahead with kind of some of the biomarker work and just some of the being able to have a springboard for intervention studies for trainees, for really a lot of different things, you're very well poised to do that. So that's what I think. Yeah.
Okay, wonderful. Thank you so much.
Thank you all.
Melissa. Appreciate your time.
Okay. Thank you so much. I really appreciate it. No problem. Thank you. Thank you very much.